This week on the BackTable podcast.
It's invigorating to the group to have somebody coming out of training and joining a group that's established. And so set up a journal club for your group, send out interesting articles, just, talk it over with your partners. Join your state urology society and go to that meeting. I think that you can get your CME online and keep your license active and keep your, board certification current, but just going to a meeting and getting a feel for what the direction of medicine is, what's new. Don't think you know something, right? Like look at the guidelines and look things up whenever you see that patient. Don't lose that kind of residency curiosity. And it starts in residency, right? Like we should hopefully be encouraging our residents to be curious and remain curious, because that's how the field will change around you in a heartbeat.
This is Jose Silva as your host this week. Today we have Dr. Lucas Wiegand. Dr. Wiegand did his urology residency at USF Tampa. Then he did a fellowship in Reconstructive Urology at WashU St. Louis. He worked in academic setting at USF for a few years, and now he's in Orlando with Orlando Health. So Luke, welcome to BackTable.
Thank you, Jose.
So Luke, so you were in academic setting for a few years. You did mainly all the reconstruction. I remember meeting you way back with Hoffman and MTACH, and then now you're in the private sector with Orlando Health. So I want to dive into first talk about reconstructive urology and also do the bridge from academia to private setting now. So let's start with just a brief introduction about your training, your fellowship. So yes, can you expand a little bit?
Yeah, absolutely. Yeah, I got a lot of good training at University of South Florida. In the days when we could kind of be on our own and be, a little more autonomy than what we have nowadays. But one of the things that I felt was missing was some of the reconstructive procedures. And so I wanted to kind of round out my knowledge a little bit more. And that's why I chose to try to apply for reconstructive urology. I was fortunate enough to get a spot at Washington University under Steve Brandis, who was a good mentor to me and did a lot of, besides just kind of the typical reconstructive urology of like urethral reconstruction and incontinence, we also did a lot of upper tract reconstruction. And he was one of the people that really encouraged me to try to apply robotics to that, because it was kind of a new idea at the time. So that was 1 year fellowship. Of course, you can't learn it all. You come out and learn a lot on the job. My first job actually was hospital employed in West Virginia for a few years, where I wasn't really able to do as much recon as I wanted. And so then I got the opportunity to go to the University of South Florida. I was there for about 8 years, and then now I'm at Orlando Health.
And you mentioned the robot. I mean, at the beginning or when you were in residency, were you training robotics, or it was mainly open and then you started on your own, try to learn robotics?
Yeah, it was, we were doing most things laparoscopic, actually. Even prostatectomies is what we learned initially. Part of my residency was at the Moffitt Cancer Center. And Julio Pausing, who is still there, did a lot of good laparoscopic work and kind of waited. He was one of the people that was kind of trying to wait and see how the robot was going to go. And so we didn't start doing robotics until toward the end of my residency. So I was fortunate enough I never really did, like for prostatectomy, for example, I didn't do very many open. It was either laparoscopic or robotic. And so we got a pretty good oncology experience robotically, but the recon stuff was all just kind of brand new.
And at that time, so you mentioned some of the things you did in your fellowship. When you decided to do a fellowship, or how do you decide? Because a lot of the reconstructive urologists that are from programs that I hear, they do mainly urethra. You have the other, the new places doing female to men and that type of surgery. So how do you decide what type of fellowship or where to go?
Yeah, the GU Reconstructive Society it's not a certificate yet, as far as like recognized through the ABU and AUA. They run the match for the Reconstructive Urology fellowships, and one of the criteria is that you have to have at least 60 urethroplasties at your center in order to even qualify to have a fellowship. But then you also have to have one other area, and that can be transgender surgery or gender affirming surgery. It could be incontinence. It could be upper tract. It could be robotics. So they have a lot of different sub areas within reconstructive urology. And so the applicants have to kind of look at each program individually and see what they want in addition to that urethral training.
So right now they're all in the same boat, and you need to get to know the programs and then decide how do you want to focus or target approach road reconstruction.
Yeah, I kind of think of it like the oncology programs. Like almost all the oncology programs out there, you're going to learn how to do a prostatectomy, but then some of them are more, maybe testicular cancer focused or renal cancer focused or, research or something like that. So it just kind of each program, it's their way of having a nuance.
So let's talk about a little bit of overview about robotic surgery and how in your fellowship you did robotic surgery or it was just starting?
So during my fellowship director, we did everything open. And then being at Washington University, they had a lot of good robotic surgeons there that I was able to kind of tag along with. Even though they weren't doing recon procedures, I was able to see how they did other oncology procedures. And so I was able to at least get an idea of some advanced robotics and then take some of that and try to apply it to recon.
And you started doing those cases while you were in Virginia or
Mm-hmm.
Yeah.
Yeah. So as a kind of a smaller area, it didn't have a lot of reconstructive opportunities. But, my journey kind of robotically, I felt always a little bit constrained with the multi-port robot. And so it's more difficult to be able to get access in a reoperative field, which is always, one of the big issues with reconstruction is that a lot of times it's a reoperative field. And so what I found was that, trying to take all the adhesions down robotically or laparoscopically and then actually dock the robot, that a lot of times it was more efficient or even safer to be open. And then I could have colleagues that could come help and when I was open and things, from other specialties. And so the uptake for me robotically was a little bit slow until the single port came on the scene. And then that's when I could the single port, I think, lends itself more to redo surgery and, skirting around adhesions and things like that. And so I've more than doubled the number of robotic cases, but in less amount of time, using the single port.
So it wasn't about going to an academic center, having the residents with you. It was mainly technology.
I think it was more technology. Yeah. I mean, I think training, having a good assistant is of course important, but I think that it was more of kind of watching others, what they did as well. I wasn't the first to do any of these things. I was just following along. And so as people were doing more and more reconstructive procedures, you could see what could be done and then try to copy that as well.
So look, where do you go to see procedures? I mean, just talking to other urologists, watching videos. Where do you go? What do you do?
Yeah, I mean, conferences are great because, you can see a lot of good stuff done. Now that most centers have video recording capabilities in almost every robotic room, like there's been a proliferation of procedures to be able to be seen. Good old-fashioned YouTube. There's a lot of different, places that we all, probably get emails from about, hey, look at these videos. I think we probably all get those. And then, I even have colleagues that are like, hey, didn't you have a video or tell me you did X, Y, Z? Or, I'll ask them the same thing, and we just send each other links.
And look, in terms of the robotic surgery, you mentioned the single port. What were your delimitations before having multiple ports? Just access to the area that you wanted to work it, or what was the difference?
Yeah, I mean, most of the time with reconstruction, we're trying to stay in one little area and focus in one little area where there's an issue. We're not having to retract a lot of things. We're not having to move big organs out of the way. And so the concept, at least for me, is regionalizing the surgery. And so initially with the single port, I was transperitoneal. And then I've really now been applying more retroperitoneal, preperitoneal, and staying out of the, intra-abdominal cavity. And so, I think that trying to apply the open concept, like whatever you would do open with the robot was able to actually be done even more straightforward with the single port for me. And so it gave me that confidence to make my incision. In the beginning, I would just make my incision wherever I would have made it open, but smaller. And then it lets you have a back out, a safety net that you can just say like, hey, look, I've already got my incision here. Everything is safe. I'm doing everything under direct vision. I'm getting access under direct vision. It's a bigger incision, at least 2.5 centimeters. And so it feels more natural, I think, to those of us that do the recon.
And so the other day I was talking to one of our onco guys in Advent with Russell, and essentially he was doing single port now, and he was saying how great the patients do afterwards in terms of pain. And especially if you go retroperineal, sometimes they say that he does a nephrectomy and really very, very rare that the patient might be able to go home the same day.
Yeah.
Is that something that you've seen also in reconstructive urology?
Yeah, absolutely. I mean, especially compared to open, the same kind of procedure. Of course, it's hands down better. With the multiport, I think it's been shown in a couple of studies, but also my anecdotal experience. You're not talking about days faster, but when patients are already doing pretty well with multiport, it's harder to show a difference. But I think it is much easier to get people to do things as an outpatient with a smaller retroperitoneal incision, for sure.
And in terms of open surgery, there are some cases that you will do open, and what are they?
Yeah, I mean, most of the time nowadays, if I'm doing something open, it is because there's a co-surgeon that, if I'm doing something with a general surgeon, that they also have some major abdominal wall reconstruction. Even then, a lot of times, whatever they're going to do, it's robot, and so it's, for me personally, almost never do I book something for just open from the start. I will have a little timeout with my team beforehand and like, hey, look, very high chance of needing to open here. Let's have all the stuff already open. Or, hey, low chance of conversion, you can keep the instruments in the box for now. If there's a big tumor that's very, very large that I won't be able to get around or see around, maybe, I could at that point, but I'm rarely doing anything, cancerous like that.
So in terms of learning curve, I mean, when do you decide, like you mentioned, before you're doing most open things, when you decide, so, okay, I'm going to do everything robotic, is just a learning curve on just feeling comfortable?
Yeah, I think, of course you have to be comfortable with whatever the intended operation is anyway, right? So I kind of think of it the way that I counsel my patients, which is I'm not going in to do a robotic procedure. I'm going in to fix your whatever. Okay. And so if you're not comfortable somehow fixing it open, laparoscopic, multiport, whatever you have to do, then you shouldn't be doing it robotically either, right? And so, but I think as long as you have your step one, hey, I'm going to try to get access here, and I'm going to do up until this point or give this amount of time to get through the operation robotically, and then if it's not going well, my backup plan is open, then I think that's, it's not a risk to the patient. The only time I see, I've seen issues is when people get so, I've seen cases where surgeons get so focused on having to complete something robotically that they'll leave a patient on the table for way too long and then have complications from positioning or, anesthesia type complications of lung issues. And so I kind of, if I'm not progressing as well as I would like in a reasonable amount of time, that's when I'm like, all right, I need to open. And so that's the same advice I give to other people.
And what's the benefit of open surgery give you versus just continue trying to do it robotically?
Yeah, I mean, I'll give you a good example of one of the cases I opened recently. It was a neobladder, and the ureters had strictured at the afferent limb of the neobladder. And the afferent limb was going under a loop of bowel, but then it was wrapped around and then it was dipping down into the true pelvis. And so there was no, even with the single port, there was no good angle to see down and almost back on myself to be able to, so I was accessing looking at the pelvis, but then the actual stricture was kind of underneath the bowel, all the way almost 180 degrees from the direction I was looking. And so in that situation, it was a decision, intraop decision. Do I open and fix it? Or do I try to put the robot in another spot and look back the other way? Maybe I waste another hour and still can't do it. And so, I take into consideration it's an older patient and how long I've already been working. And I'm like, look, I'm just going to open because then I know I can do it. And I've got retractors. I got 10 retractors that I can put in there, and my assistant can be more active, and I know I can get the job done in a reasonable amount of time.
So it was a matter of visualization and the angle that you were in, essentially.
Yep. And I know there's other urologists out there that would just put the port in a different spot. And I think that's not wrong. It's just my personal preference. It's also not wrong to ever open.
No, and that point, it's always, there's no right answer. Like you mentioned, keeping that patient in anesthesia longer versus, so in my case, I don't do reconstructive urology, but definitely there are cases that are quicker for a patient that less anesthesia, others will take longer. So even like a PCNL for me is quicker sometimes than going to do a ureteroscopy and stay there an hour and a half when I can do it in 20 minutes, even though it's a more invasive procedure. So there's no right answer for that, I guess.
Yeah. Yep. I agree.
So Luke, we discussed open versus robotic. Essentially, you mentioned that there's no anatomical or no diagnosis at this moment that you say, hey, this patient or pathology, that this patient will need open surgery versus a robotic. How did that change in academic versus private setting? Was it a transition? How was the transition?
Yeah. It's interesting with training the residents nowadays that it has changed from kind of like what I mentioned before. There's less autonomy. A lot more residents are going on to do fellowships where they then get the autonomy, and it's almost like the training has gotten longer. It's by a year or two. And so, number one, I never used residents as assistants for the most part. Some of the junior residents would, and I'm sure if they listen to this, they would disagree with me. But I tried to not use them in any way that I wouldn't do myself. And so for the single port, for example, if they were at the console, because it's only a single console, then I would scrub in and assist. So when I transitioned away from having residents, I knew I would need more than just a scrub person. I do have the benefit of having a physician assistant who's very good. She does a wonderful job. And for single port, though, you do need a little bit less assisting. You lean on them a little less. What they do is a little more difficult, but there's a lot less of the suctioning. You suction for yourself. There's a lot less of the retracting. There's not really room to put any retractors in there. And so that's one of the things that I like anyway, is trying to make it so that anyone can assist. I feel like if you set your surgery up right, then typically a novice assistant won't hold you back. And so I feel like that would benefit most people to think of how can I make it so the assistant, I'm not dependent on an assistant. And I really tried not to do that when I was in academics.
And that was when you started the first time you went to a private setting in Virginia, that was the approach to that scenario.
Yeah, absolutely. I think that with training residents especially, like you want them to know how to do the operation. Of course, a good assistant does make a big difference. It can make things go faster, but trying to teach them how to actually do the operation is really more me assisting them. And so that's more what I would try to do, or even scrub out and watch them do it so that I could, not resist the urge to take over or do something for them.
And I was going to ask, so you mentioned that now, residents are not having the exposure as before. Is it that attendings are not letting the residents do more? Is it more that there's more people watching you? Why are residents now doing less than before?
It's weird. I've thought about this a lot, actually, and I don't know that I know the answer any better than anybody else, but my personal take on this is there's been a trend toward more people doing fellowship before there was less autonomy. And I think that because there's that idea of like, hey, I'm going to go do a fellowship anyway, then it's been like more accepted that you have a little bit less autonomy. And then the fellows are also there learning, so it takes away some of that from opportunity from the residents. There's been less of with some of the high profile cases that have been out in the news as far as surgeons working in more than one room at once and things like that. There's less of that's possible nowadays with residents. And so you have the attendings that are present, whereas before they would have been kind of bouncing back and forth between two rooms. And, I think maybe the residents we're selecting are a little more wanting to be shown things. It's not a worse system. I don't know that it's worse, right? I think that high quality but less interactions, or high quality but less autonomy, is probably much better than just being thrown out there and figured out, or the old see one, do one, teach one. I think that we're probably becoming better teachers because of this as well, as we interact with the residents more.
So let's talk about day-to-day difference between academic and private setting. What was the big change? I mean, if you want to go also answer why was the change from your change from academia to private, definitely would love to hear that.
Yeah, no, I mean, I was at USF. I did my training there. Those are my friends and family, the faculty that I left behind. I was looking to branch out. And, one of the things I'm working on at Orlando Health is starting a residency. And so this is my opportunity to kind of put my own mark on the way that residents are trained. And currently we're pending finding out if we're going to have that or not. But I think that whether we get approved or not, we're going to keep pushing for it until it happens. And I think it's going to happen. That was the big thing for me, was having that chance to kind of branch out and start something new.
And the transition, I mean, compared to the day-to-day, was it different? It was challenging?
Yeah. Like most things in life, the institution at large is kind of sets the direction a little bit, but for the most part, you're interacting with the same couple of people over and over with. That really sets your day-to-day, feeling and mood. The leadership here at Orlando Health, I'm very happy with. They do a nice job. They let us kind of do our thing and are very supportive. And so, the transition for me, one of I think the line between academic and kind of a larger institution, like the institutions like the ones we work for example, is really being blurred. I have access to research resources with research coordinators and, an internal IRB and all the kind of same stuff I had at USF. I have all the same resources for the most part to get an assistant if I want. There's first assist, or like I said, I have my PA. To me, the real difference nowadays isn't so much between academics and like hospital employed, but it's like academics and either private equity or, academics / hospital employed and private equity or true private practice, which is even rarer nowadays. But most of us are not our own boss anymore.
Definitely. I mean, like you mentioned, health systems is maybe right now we don't have a residency program, but we're also bidding for one. So hopefully we get it. But like you mentioned, the lines are very blurred, and we do. I mean, there's people watching us just to make sure that we're following guidelines, making sure that it's not like we can do anything that we want in terms of harming patients. There's always a lot of people watching you. Make sure that you have quality and the product is good.
Yeah, I think I'm glad you brought up the quality, because if you take it as somebody trying to direct your care, then it can be offensive. But I think if you embrace it and you try to direct the quality yourself and say like, good, I'm glad let's talk about quality. This is what I think is important. And that's actually one of the things they do here at Orlando Health that I like, is like, what do you think is important for quality? Okay, good, we're going to measure that, instead of something totally random that doesn't, make any sense. And so I think partnering more than trying to make it adversarial with these health systems is very, very beneficial.
Yeah, I completely agree with that. So look, in terms of case complexity, volume, are you doing more or less what were you doing in USF? Or because here, the volume here in Central Florida is crazy, so.
Yes. Yeah, there's, as you know, and as I know, there's like more than enough business. We could all hire a bunch more people and still all be busy, probably get busier somehow. And so, there's just more and more people moving to Florida, more and more people aging into the urologic diseases. Yeah, I think that complexity-wise, the thing that I've noticed is that the patients are not getting any younger and everyone's living longer. And so I think just everyone's complexity is increasing. Everyone is sicker, and being, one of the miracles of modern medicine is the people that we can keep alive and kick in. And then of course they get a kidney stone or they get some sort of urologic problem. And, you're faced with a decision of like, hey, do we tell them there's nothing we can do because they're too sick, or do we take a shot at trying to do something to make their quality of life better? And it's difficult. We're almost, I think, get a little bit numb to it. But as far as like the everyday, I'm not going to turn anybody away. If you need surgery, you need surgery. And then you have to decide, with true informed consent, which is what I really tried to let people know is it worth the risk to you? And that's where that conversation with the patient is so important.
No, I have sent to you patients with, we usually women with radiation, history of vaginal or cervical cancer, distal strictures, and with nephrostomies. And essentially, like you mentioned, it sometimes they have suffered enough that they don't want to continue suffering, and they just continue with the nephrostomy. That's their decision. Mm-hmm. Even though you do procedures to help them and get them rid of catheters, but sometimes they just don't want to suffer, even if they're young.
Yeah, absolutely. The women, especially the radiated cervical cancers and things like that, they have a lot of really difficult complications. And like you said, they're younger. And so that's really, really tough. And they just want to live their life, and they're willing to kind of just do whatever it takes to get back to their life. And sometimes it is avoiding another major surgery or the risk of another complication, for sure.
Exactly. What do you miss the most of the academic setting? I guess the residents, but...
Yeah, no, I mean, for sure the residents, it was always fun to watch them progress. And, the residents just graduated, I saw their, all their posts online and everything about graduation. And, these guys were like med students with me at one point, 6-7 years ago. That confidence and that progression that you see, that to me was kind of the best part. The rest of it, you can set up your practice however you want. And so, wherever your setting is fine. And so I've set up my practice well, but that being able to be a mentor and then, see them grow, that's really fulfilling.
And then you came to a setting that really in Central Florida, I mean, we have Justin, he was doing some recon, but he was so busy doing the oncology part. So you came into a place that needed reconstructive urology. Mm-hmm. So how was that process of establishing a practice? Most people knew you already because some cases were referred to you to USF from Central Florida area. So how was that process of building a practice?
Yeah, I think that was one of the discussions I had when coming over here was, what's the need? I think every urologist knows that there's pretty much a need everywhere for reconstructive urology, and patients will travel because the patients are understanding now that, it's a specialized field just like everything else. And so I have tried for a long time to maintain communication with all my referring providers and do educational events throughout the state and throughout the country to try and spread the word that I'm available. I started my own website, not for advertising, but just to kind of create awareness so that people are able to find me. And the interesting thing, even like this conversation right here, technically our hospital groups are in competition with each other, but we are, we're all in this for the better care of the patient. And so, you have a wonderful reconstructive urologist in your group that, we both have our areas of sub-expertise. And so we share patients back and forth from that standpoint for wherever it's going to be the best for the patient. And so, I think that keeping focused on the patient and getting them the best care, of course. And some of that, though, is making sure that people, patients, other urologists are aware that your services are there.
Good. So in terms of Cool. You mentioned already collaborating with other general urologists. So when you came in, you had a bunch of patients piling up just waiting to see you?
Yeah. Once I signed, then it was, kind of sealed. And so there was a little bit of a waiting list. It didn't take long to fill up and get going. The bigger thing for me was, I knew there were resources available, but for me, it's not me alone doing a lot of these really complex procedures. I need a plastic surgeon. I need a colorectal surgeon. I need gynecology. And so it was going out and meeting people, seeing there's a special type of surgeon that wants to collaborate with especially with the reconstructive urologist, who isn't afraid to get into that radiated field and, and have a little bit of a mess on your hands for a while. And so you find out who those people are, and then you try not to overwhelm them.
And that happened after you already joined OH?
Yeah. I mean, I had talked to the partners that I have now and made sure that, they knew people, and that there was support from, the multidisciplinary support to go into a little corner of the state somewhere where it's just me and no other surgeons. That would not work well for me. I need to be, the hospital where I work, Orlando Regional's a level 1 trauma center, massive, all the same benefits of any academic center.
And you do a lot of complex intra-abdominal cases. I mean, how often do you use buccal mucosa?
Buccal mucosa? Yeah, I mean, we use buccal for everything in reconstructive urology. A lot of the reconstructive urologists out there will put a buccal graft on any ureter. And I think you're talking about ureters mostly, right? Yeah. I have found, and there's a small minority of us that think that you could mobilize the ureter a little bit better sometimes and do an end-to-end anastomosis. And so I'm in the camp of trying not to use buccal mucosa. Then there's the camp that thinks you should always use it. And I don't know which one's right. But I think that it works, but it's not as good as having normal ureter to normal ureter. And so it's even the same thing in the urethra. It works, but it's not quite the same as having normal urethra put back together. The difference in the urethra is that transecting the urethra causes a lot more erectile dysfunction. So we really try not to transect the urethra anymore. But the ureter, there's no downside to transecting it whenever it's in really bad shape. And so I think that the jury is out on that one.
And in terms of the graft, are you do it yourself?
Yeah, that's one of those, the first day of fellowship, my fellowship director's like, I'm going to show you this, and then it's your job the rest of the year. So it's any urologist can do it, though. I mean, it's a little daunting at first, but the pitfalls are few, and it heals really well.
So look, we cover a lot today. Let's say if a resident is interested in going to GERS, what do you recommend? Do you always recommend having a fellowship?
Yeah, if you want to do reconstruction now, I think there's so many advantages to doing a fellowship. It's getting harder and harder to kind of be a jack of all trades, and it feels like in the medical field. And if you have that fellowship, that's never going to be taken away from you. It's another part of your education, and you're always going to get some instant credibility in that field. From what I'm hearing, a lot of health systems now are putting an actual financial premium on fellowships. And so I think that whereas in the past you would do your fellowship and then basically it's just like a year lost, you come out and get paid the same as everybody else. Now there's a little bit more push toward that financial premium. And so it'll financially pay off in the end. Like everything, like every specialty, even in reconstructive urology, for example, the procedures I do take a long time and don't reimburse necessarily as well, or even, if you're on an RVU system, even have as good RVUs as some of the other procedures. So if you're looking to do a recon fellowship and you're doing it for the money, that's not necessarily smart, right? Like none of us should be doing it just for the money. If you love recon, if you're only going to be happy, doing some of the more complex cases, then I think you absolutely should do it. Another good reason to do it is just to be able to bail yourself out. There's people that are kind of more oncology focused, but hey, if I have this problem, then I want to be able to go fix it myself or do my own incontinence after prostatectomy. It makes a lot of sense to me as well.
In terms of open versus robotic, or in the sense that how are residents going to be trained in open surgery in the robotic world? What do you recommend there?
Yeah, I think it's a real conundrum. I think the general surgeons have that issue. I think, I've just proctored a thoracic surgeon on single port. I've proctored breast surgeons for single port. It's going to be better and better for the patients, but in those situations where, hey, we got to open this real quick because something's gone wrong, that is becoming rarer and rarer that people even know how to use a Bookwalter, for example. And I don't know that anyone has an answer for that right now. Trauma surgery is still about the only place, like general surgery trauma, where people are getting big
maximum exposure.
Anymore. Yeah, maximal exposure. Sometimes, some of the bigger hernias and things, that is where people are getting this. And so there's been, I don't know if it's real or not, but people talking about open fellowships where you actually learn how to, do open surgery in a fellowship. But
another thing is, what patient is going to go to that hospital?
Right. Yeah. I mean, I guess the question really ultimately is going to be, do we need to really remember even how to do it? Because there's a lot of surgeries that go by the wayside, a lot of technologies, a lot of things that just go away, and maybe we don't know how to do it. Maybe we just need, I think the next generation of surgeons after me is going to be so used to the robot that even complications that I would open for, they're like, nah, I got this, and they just take care of it.
Yeah, probably. Just like the case that you mentioned, maybe the next generation of robotics, the scope changes angle, and then you don't need to reposition or anything.
Yeah, it'll be so innate for them that they're like, oh, I've seen this, or even they don't even have to think about it. Like it just, makes sense to them and they just do it.
And for residents going into or just finishing residency, what recommendations can you give them in terms of how to stay current post-training?
Yeah, I think that get involved with your group, and a lot the new residents joining groups. I think it's invigorating to the group to have somebody coming out of training and joining a group that's established. And so if your group, I'm assuming somebody's joining a group or a hospital system, right? Like that's what most people are doing. Set up a journal club for your group. Send out interesting articles. Just, talk it over with your partners. Join your state urology society and go to that meeting. I think that you can get your CME online and keep your license active and keep your, board certification current, but just going to a meeting and getting a feel for what the direction of medicine is, what's new. Don't think you know something, right? Like look at the guidelines and look things up whenever you see that patient. Don't lose that kind of residency curiosity. And it starts in residency, right? Like we should hopefully be encouraging our residents to be curious and remain curious, because that's how the field will change around you in a heartbeat.
Now, you mentioned, definitely the regional or the local meetings are great. You can ask other of your colleagues or friends that you saw when you were back in residency any stupid question. I remember back in December when we had the Florida Urological, I was asking a friend of mine if the patient has a painful erection at night when he wakes up.
Yeah.
And then it's recurrent and you don't find anything. What medication do you give? He said, give him Cialis and see what happens. Right. But it's stupid questions like that definitely, those meetings are great just to talk about that in the bar, something like that.
Absolutely. Without a doubt.
So let's talk about what recommendations or what tips do you give a patient or somebody or somebody that's going from academic to a transition practice to hospital setting or private equity? What things do they need to be looking for prior to making the decision?
Yeah, anyone that, I helped a lot of residents through the years look for jobs, and then interviewed a lot of people at both the academic center and even here at Orlando Health. And if the big dividing line is if you somehow want to have a lab, if you need true protected time where you don't want to have to worry about production, probably then you need to be looking at a hybrid job, an academic job, something like that. But there aren't a lot of academic centers that don't pay for productivity anymore. Everything is productivity based. the choice, the transition, any of those things, I would say, again, the line is so blurred that it's hard to make a distinction nowadays between what's academic, what's not, the private equity, I think is interesting because then you have a whole other
business
investment.
Model.
Yeah. I mean, it's investment at the same time. And so that's when you kind of have to get, even more so lawyers involved in and figure out what you're getting into and what the pitfalls are. I think there's so few companies and so little juice left to squeeze there. I think it's definitely buyer beware right now for people joining private equity late in the game like this. But that's definitely a controversial statement, as you probably saw from Florida Urological Society last year. And,
yeah.
And it's a hot topic, but everybody has a pretty strong opinion on that.
No, I guess like you mentioned, I mean, they're just hoping that they get bought and get catch out or something like that. But thankfully, it sounds like you also have a great relationship with your leaders and with administration, and I will say right now we're in a good position in both places.
Yeah, absolutely.
Luke, anything else you want to add? I think we covered a lot. I think you gave a lot of good recommendations for rising residents and other new urologists out there.
Yeah, no, I mean, I think that, from that standpoint, trying to, what I would kind of take home message for me is trying to be that expert in the field. And so some of that also goes along the credibility standpoint of having some publications. And it is definitely not an academic thing that you have to be an academics to get published. Anybody can write up anything, get their own data, analyze it. The AUA offers statistical services that you can pay per hour. I mean, there are, it might be a little bit of a financial investment, but we all are, paid pretty well, and to get some of that information out there, even if it costs little money, the return on that for the patients, is good. And then even personally, you're not going to get paid back, but the credibility you get from staying current and writing a paper, and it touches on a lot of those things you were asking about. I think that we should all be counting something. I think there was Atul Gawande who said that in one of his books. I can't remember now, but always be counting something as far as your outcomes, and see what you can put out there and help your colleagues, help the patients.
And look, if somebody wants to refer you a patient, what's the easiest way to do that?
Orlando Health, main number, that website they can go to, or they can go to my website. Just, Google Is Your Friend and send me a message.
Excellent. Well, Luke, thank you for all your knowledge and time, definitely. I'll be seeing you around.
Absolutely. Thank you. This is a lot of fun. I appreciate the opportunity.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.